Okay, everybody, we are back and we're going to finish this up. All right. So, in regard to biological therapies, so we've moved on from specifically like the biological approach, but now we're into biological therapies, and we'll go through a couple of other therapies as well. But um, with biological therapies, the primary biological therapy is going to be medication. That's what we've been using for decades and decades. And these are going to alter the functioning of neurotransmitter systems. Uh, Medications can be helpful. They are not an end all be all. With some medications, they're just going to act as a band aid. Some people may actually have, again, neurotransmitter malfunctioning, and they can work very well, but we will talk about this. Medications are people are so quick to say like, oh, I just need a medication, I need an antidepressant, anti-anxiety, give me Xanax. Like it's not the most effective approach. They often both have therapeutic effects, like yes, it might decrease some of your depression. If we're talking about something like Zoloft, what we will see sometimes with Zoloft is yes, it's going to take probably 4 to 6 weeks to gain full efficacy. In the long run, yes, it may decrease some of your your depression, but in the short term, we do see increased suicidality. So there's some of your side effects. We also have brain stimulation techniques. We have ECT, and this is your electroconvulsive therapy, like we talked about. We have also RTMS, or repetitive transcranial magnetic stimulation. This is literally when they put a magnet up against your head and pulse magnetic waves through your brain to basically realign those neurotransmitters. Deep brain stimulation and vagus nerve stimulation, again, to change the chemical composition and functioning of the brain. There's also psychosurgery, but we really don't do it that much. Kind of getting into the lobotomy area here. This is when a neurosurgeon attempts to destroy small areas of the brain thought to be involved. Apologize for this. Just 1 second. Hopefully this goes through because I just saved your other video. Fingers crossed. But again, they're basically destroying a small part of the brain thought to be involved in the psychological disorders, similar to lobotomy, but obviously here it's going to be more precise. But it's only used rarely. It's going to be used with people who are very severely mentally ill and no other treatment has worked. Way down the line. Okay, so some drug therapies for psychological disorders. All right, so we have we'll talk about all of these in every associated chapter. So we do have antipsychotic drugs. This is going to be like Thorazine, Haldol, Clozaril. Some of there's also, we have first gen, second gen antipsychotics. What antipsychotics primarily do is they're going to reduce the positive symptoms of schizophrenia. In abnormal psychology, positive does not mean good. Positive means we're going to add something that shouldn't be there. Negative means we're taking away something that should be there. So your positive symptoms of schizophrenia are going to be things like hallucinations and delusions. Those are something that's there that should not be there. And what happens is during a hallucination, again, it's going to increase the activity of dopamine immensely in the brain, causing those hallucinations and delusions. And so what you will see these antipsychotic drugs do is try to bring down the level of dopamine activity, thus decreasing those positive symptoms. We also have antidepressants. There aren't really MAOIs used very often. I haven't seen it in quite a bit of time. Like Parnate, maybe tricyclics are used once in a while, but rarely. You're going to see mostly SSRIs and SNRIs. Your SSRIs are going to be things like Prozac, Zoloft, Celexa. Those are your SSRIs. Those are going to work on serotonin specifically, but then you have your SNRIs. We'll talk more about this because we're pretty sure now that serotonin is not always the common denominator in what's causing depression or a lack of serotonin. It's not always. I'm going to say it's not really usually, based upon our research. And so you have SNRIs now because they thought, okay, now maybe norepinephrine has something to do with it, because when somebody's depressed, not only are they feeling helpless or hopeless, they have a hard time getting up and doing things commonly. They have lots of fatigue. Things are moving slower. It's hard to get out of bed. And the thought is that that's low levels of norepinephrine, and that if we up the norepinephrine, at least that fatigue and slowness and sluggishness won't be there. And that might be part of the overall depression. So we have drugs called SNRIs that address both the serotonin deficiency and norepinephrine deficiency. And these are going to be ones like Effexor, Cymbalta, and I'm going to blank on most of them right now. But again, we'll talk about those when we get to depression. Also, lithium is out there. That's going to be primarily used in bipolar disorder. Lithium is literally the compound lithium. It is lithium like found in like your batteries. That is lithium. It's not just a fancy name. It is lithium. It's going to reduce symptoms of mania. So things like agitation, excitement, grandiosity, impulsivity that comes along with bipolar disorder. And these are some examples of it. They really don't like people to be on lithium for extended periods of time because of the damage it can do to one's body. Then we have anti-anxiety drugs. These are primarily going to be, of course, are going to reduce anxiety, fearfulness, worry, tension, things like that. You might see some barbiturates out there, things like Nebutol, but more often than not, you're going to see drugs like benzodiazepines, benzos. And when we talk about anxiety disorders, again, I'm going to say never, unless it's extraordinary anxiety that's never been treated before. Otherwise, therapy first, meds second. Medications for anxiety are nothing more than Band-Aids. They will help for the moment, but then as time goes on, they will lose efficacy, and benzos are addictive. And so you have these benzos like Valium, Klonopin, Xanax. And as I'm saying those, I think everybody's like, oh yeah, that is pretty addictive. Yes, we will talk about that. Okay. Now, let's see here. Assessing biological approaches. Yes, they're going to have side effects. Everything's going to have a side effect that we have going. Nothing is perfect. Yes, we do worry that some people are going to turn directly toward the medications and not look at other ways to ameliorate those psychological issues. They do often ignore the role of environmental and psychological processes in biological functioning. We'll talk about that. And also, it's not a great approach to only, the biggest thing is it's not a great approach to only lean on like psychotropic medications, or that it's something neurotransmitter wise. There's many approaches to psychological disorders that can be helpful. Let's see here. There are, in regard to behavioral therapies, we talked about behaviorism. So we talked about like operant and classical conditioning in intro. And so there's therapies related to this. Also, there's cognitive behavioral therapy. And it focuses on influencing like the influence of reinforcements and punishments. And how do we change behavior? How do we change behavior? That's the gist of it. And some of these are going to be like the removal of reinforcements. So removes the individual from the reinforcing situation or environment. So if there is a situation that's causing immense anxiety, maybe we remove them from it. Aversion therapy makes a situation or stimulus that was once reinforcing no longer reinforcing. This can also be done biologically. So an example of this would be anabuse, but this would be more, again, therapeutic. You're not taking the drug, but what anabuse does is you take the drug, and every time you drink, it makes you very sick, thus creating an aversion to it, and hopefully you stop it. Relaxation exercises, yes, controlling, like heightening it when anxiety heightens. How do we bring that down? Things like deep breathing, meditation, mindfulness. Distraction techniques, I recommend these. It helps the individual temporarily distract from maybe anxiety or depression, whatever one's feeling. And so, I recommend everything from like coloring to taking a walk. I've recommended TikTok in very low doses, of course. Flooding or implosive therapy. This one is, I don't know if I would recommend this, but it exposes the individual to the dreaded or feared stimulus while preventing avoidant behavior. This is pretty hardcore, pretty upfront, in that this would be as if, let's say I'm afraid of snakes, terrified of snakes. And what happens is my therapist shows up and drops a snake in my lap. That is flooding. You are going to expose that person right now to whatever it is. I would be more prone to recommend systematic desensitization, because what this does, it pairs, again, mindfulness, meditating, deep breathing, with a hierarchical exposure to the aversive stimulus. So maybe I'm afraid of snakes, but you know what? What we're going to do is, we'll see here, we'll work on relaxation techniques, and I'll put a picture of a snake on that very, very back wall. Okay, it's going to cause anxiety, but As time goes on, I continue to relax and normalize it. Okay, then maybe the picture comes a little bit closer and closer. And then maybe there's one point at which the therapist, shows a video of a snake. Okay, then we get used to that. Again, this could take like years, possibly, depending upon how phobic a person is. And then you work slower, just slow baby steps toward the point, like one day you might be holding a snake, but it's not immediately like flooding. We also have response shaping through operant conditioning, like pairing rewards with desired behaviors. If you don't drink for the next week, I will buy you a puppy. That's just operant conditioning. Behavioral contracting, providing rewards for reaching goals. That's something that we worked on when I was a community sport care coordinator. We would set goals. And if people achieve their goals, there would be certain types of rewards at the end. Modeling and observational learning models desired behavior so the client can learn through observation. So helping them understand how an example might be like there's some sort of something like schizophrenia might require some life skills type of classes, and modeling can be very helpful with that to kind of show them ways to approach like social situations or interacting in society. Okay, there's also cognitive theories. So behaviors, what are we doing? Cognitive, what are we thinking? So human behavior is motivated by more than associations, rewards, and punishments. Again, cognitions, thoughts and beliefs. Those are going to affect our emotions and our behavior. So it's going to affect those psychological symptoms. So we look at like causal attributions. This is a meaning given to an event. It affects how people feel about it and respond to it. And again, if I'm terrified of snakes, that's the meaning I give to snakes. And thus, as a result of that, if there's a snake present, I am leaving. I'm leaving. I might cry. I might scream. Again, it's the meaning we give to it. That's not necessarily the objective reality, but that's the meaning we give to something. There's also global assumptions, and there's a broad beliefs about oneself. Things like I'm worthless, I'm not, I should not be loved, I don't deserve anything good in life. Those are very common. Relationships, I don't deserve a relationship, and the world affect moment-to-moment interpretations of events. So if you feel that way about yourself, you're going to act a specific way in your environment. And so what these therapies do, they're going to identify these things. They're going to identify these causal and global attributions, and we're going to replace them, like replace the irrational thoughts. Yes, you are worth something. You do deserve good things. And we're going to slowly change those perspectives into realistic ones. We look at problem solving skills, and it is designed to be short term, but it can go for years. So again, this CBT, cognitive behavioral therapy, again, cognition and behavior. Let's see here. Cognitive, especially like CBT, it has been found to be useful for things like sexual disorders, depressive disorders, substance abuse disorders, anxiety disorders. It's huge. Bipolar disorder, schizophrenia, most. There's only some that we will talk about in which this would not be appropriate. So there's also some third wave approaches. And the one that I really wanted to talk about is DBT. It's dialectical behavioral therapy. It's a little bit newer, and it's going to address challenges in managing negative emotions and controlling impulsive behaviors. So this is great for emotional regulation. If somebody does not have great emotional regulation, emotional dysregulation, so they have a hard time controlling their feelings. They get very rageful, like it's as if their anger, let's say anger, for example, it just builds and builds and builds and builds, and they can't bring it back down. That's emotional dysregulation. Dialectical behavioral therapy brings everything back down. It teaches people how to do that, because sometimes what happens early on in life is people don't learn how to emotionally regulate. That can be due to a variety of factors. And so we will talk about that in depth, specifically when we talk about a few disorders. Now, there is new technology to deliver treatment. I'm sure you see BetterHelp commercials all the time. We have the internet, we have smartphones. And now, so interventions can be made available, and they're effective to underserved populations. So like people, okay, we're out in the middle of nowhere. We have more access. Developing countries, so we can go to low income countries and people with modest incomes. It's affordable, kind of, little bit, sometimes. That's what I'm going to say about that. Also, I talked about sociocultural approaches, looking beyond just the individual or their immediate surroundings, looking at the wider society and the world to understand why people have these problems. Again, we can talk about anxiety in our society or a variety of psychological disorders. And so some of the risk factors for mental health problems: socioeconomic disadvantage, poverty, upheaval and disintegration of societies, if one becomes a refugee, if one lives through a genocide, if one lives through a war, social norms and policies that stigmatize and marginalize certain groups. So if you think about that, individuals that might be people of color, individuals who are sexual minorities, individuals who are gender minorities, individuals who are in the minority in some group, age minority, ethnic minority, nationality minority. We can go on and on. And also implicit and explicit societal rules about what types of abnormal behavior are acceptable and which are not. So the biggest gist about this is that, there's a possibility that maybe if we possibly improve the lives of people, they will be less apt to develop psychological symptoms and disorders, which does make sense in regard to that biological approach, is that even if you have that genetic predisposition, if you don't go through that stressful event, whatever it might be that, fills that glass, we decrease the chances of that ever developing in the first place. It's just food for thought. Okay, we do have some prevention programs, primary prevention, stopping the development of disorders before they start. Again, addressing mostly those stressors before they start. Secondary prevention, detecting a disorder at its earliest stages to prevent the development of the full-blown disorder. So you're looking at somebody who's starting to exhibit signs of anxiety, starting to exhibit signs of like bipolar disorder, and we get them in and we start to treat them before it becomes full-blown and negatively affects their lives. Then we have tertiary prevention, and this is when we prevent relapse and reducing the impact of the disorder on the person's quality of life. They've already developed this disorder, they're full-blown, now we're going to treat it. Now, the common elements in all of these: positive relationships between professionals and clients. That's extraordinarily important. Without that positive relationship and trust, it doesn't work, even if we're just talking about medication. An explanation as to why this is happening or what is happening goes a long ways. And then also, especially in regard to like therapy, encouraging people to confront painful things, uncomfortable things, and accepting, being open and accepting. That's the biggest thing with therapy in the first place. If you're not open to it, it doesn't work. Until somebody's open to it, none of it works. None of it. And so as a result of that, that's what's going to be the most effective. So with that being said, that is module/chapter 2. If anybody has any questions or concerns, feel free to reach out to me. I hope everybody's having a great day, and I'll talk to you later.